All right, welcome back to the deep dive. Today we are strapping in for a high-velocity, high-stakes sprint through one of medicine's most critical challenges, managing massive hemorrhage.
hmm
And we aren't just reading academic abstracts today. We're diving directly into the kind of distilled, authoritative teaching material used in trauma centers.
That's right. And this material is special because it comes from a slide deck from the Department of General Surgery at AIIMS Nagpur, put together by Associate Professor Dr. Senthil Kumaran.
So this is frontline practical knowledge.
Exactly. This is the blueprint for immediate action. It's what's taught to surgeons and residents who need to make life or death decisions in seconds. It's designed to be sharp, precise, and actionable.
Okay, so our mission today is to unpack that essential knowledge. We're going to focus on the specialized transfusion protocols that define success and, maybe most importantly, dissect this insidious feedback loop known as the lethal triad.
And that lethal triad really is the absolute core of our discussion today. The core question is this: how do medical teams stabilize a patient who is, literally losing their life force second by second?
And what specific physiological cycle, this cycle of death, has to be broken immediately?
It's a race against the clock, absolutely, but it's more than that. It's a race against the patient's own body turning on itself.
Okay, let's unpack this then. To understand the crisis, we have to start with the fundamentals, right? The biology. What are we actually losing when we talk about massive hemorrhage?
Yeah, you have to know the components to know what to replace. Blood is often just thought of as, this red fluid, but technically it's a fluid connective tissue.
And it's roughly split, what, 55% plasma and 45% cells?
That's the breakdown. And that composition is what dictates the failure points. That 55% plasma is mostly water, sure, but it's also got proteins, electrolytes, and critically, the clotting factor.
The things that stop the bleed.
Exactly. And the other 45% is cellular. You've got your red blood cells, the oxygen carriers, white cells for immune defense, and then platelets, which are the little cellular plugs for clotting.
So when you lose a liter of blood, you're not just losing volume, you're losing 5 essential interconnected systems all at once.
All at once, that's the key.
The teaching materials list 5 key functions. We've got oxygen and carbon dioxide transport, nutrient and waste transport, immune defense, and then the 2 that seem most critical for trauma, coagulation and temperature and pH regulation.
And in a trauma setting, you're right, coagulation is the absolute frontline defense. The body needs to physically stop the leak. But here's the thing that's so crucial.
Go on.
The ultimate failure isn't just mechanical, it's chemical. That's where temperature and pH regulation come in. It's the foundation of the lethal triad we keep mentioning.
Oh, so?
Well, if the blood can't maintain its core temperature, or if it can't buffer the acid that builds up during shock, the entire clotting machinery it grinds to a halt.
So the environment inside the body becomes hostile to the very process that's trying to save it.
That's a perfect way to put it. These are the 2 functions that fail first, and then they compound the whole crisis. It's why just surgically stopping the bleed isn't always enough. You have to treat the blood itself.
Okay, that makes sense. So let's move on to how bleeding is classified. I assume this helps the team figure out the urgency and what to do next.
Right. The first classification is by source, which is pretty straightforward. You've got arterial, which is pulsatile and bright red because it's full of oxygen.
Then venous,
which is that darker, steady flow. And finally, capillary, which is more of a diffuse ooze, basic triage stuff.
But the source material says the most important classification, the one that hides the real danger, is by timing.
Yes, this is so important. Primary bleeding is obvious, right? It's the immediate loss after the injury. But then you have the hidden dangers, reactionary and secondary bleeds.
Okay, explain reactionary bleeding. It says it happens 4 to 6 hours after the injury or surgery. That feels like a ticking time bomb.
It is an absolute time bomb, and it's why the postoperative period is so incredibly dangerous.
What's happening there?
Think about it. During surgery or right after an injury, a lot of things happen. Small vessels might be clamped, or they might just spasm shut because of the adrenaline rush or the low blood pressure from the initial shock.
So they form weak plugs.
Weak temporary plugs. Now, hours later, the patient starts to warm up. Anesthesia wears off, and their blood pressure starts to come back to normal, or maybe even a little high.
And that increased pressure
Blows those weak clots right out of the vessel, and the bleeding starts all over again, but this time it's internal. It's hidden. The patient can crash hours after everyone thought they were stable.
Wow. So the team is diagnosing a catastrophe based on just subtle changes in the vitals.
Exactly. And then you have secondary bleeding, which is even more insidious. We're talking 7 to 14 days later.
That can't be a mechanical failure at that point.
No, it's systemic. It's almost always linked to infection. Bacteria and the body's own immune response can literally erode tissue and chew through a vessel wall that was, initially fine.
So that requires a totally different response.
Completely. You're not just chasing the bleed, you're fighting sepsis or necrosis.
And the final classification is by management need. Surgical versus medical. This is where we get into things like DIC, right? Disseminated intravascular coagulation.
Right. And DIC is a catastrophic failure of the whole system. It's a paradox. The body is triggered by something, usually massive trauma or sepsis, and it starts clotting everywhere.
Everywhere.
In all the tiny vessels all over the body. But in trying to clot everywhere at once, it completely burns through its supply of clotting factors and platelets. It empties the supply cabinet.
So the patient starts bleeding uncontrollably because they've used up all the tools to stop bleeding.
That's the paradox. They're bleeding from every IV site, from their gums, because the coagulation system is exhausted. You can't operate on that. You can't clamp DIC. You have to medically support them with massive amounts of blood products to try and restock that cabinet.
So you have to know immediately. Did the vessel fail, or did the blood itself fail?
That's the fundamental question.
Okay, so when a patient comes into the trauma bay, the clock is just ticking like mad. You can't wait for lab results. The first line of defense has to be clinical observations.
Absolutely. You're looking for the body's frantic fight for survival. The first signs are things like pallor, sweating, and anxiety.
The classic fight-or-flight response.
It's the sympathetic nervous system going into overdrive, trying to maintain circulation. And the first vital sign you'll see change is tachycardia, a fast heart rate.
The heart's trying to compensate for the dropping volume by pumping faster.
Right. But here, and this is a major, major clinical trap that the source material highlights perfectly, hypotension or low blood pressure is explicitly marked as a late sign.
A late sign.
A very late sign. And you really can't stress this enough. If you wait for the blood pressure to drop to diagnose a massive hemorrhage, you've made a fatal mistake.
Why is that? Why is it so delayed?
Because the body is an incredible compensation machine. When you start losing blood, say up to 30% of your volume, the body unleashes these potent vasoconstrictors like adrenaline. They clamp down on all the peripheral blood vessels.
Squeezing the remaining blood to the core.
To the heart, lungs, and brain. And this constriction keeps the blood pressure deceptively normal, even while the patient is, frankly, circling the drain.
So by the time the BP finally drops, the compensation mechanism has failed. The patient has run out of fight.
Absolutely. The vessels can't squeeze any harder, the heart can't pump any faster, and you see other signs of this failure. Cold, clammy skin.
Because there's no blood flow to the skin.
Right, it's been sacrificed. And a liguria-low urine output. The kidneys are one of the first major organs to get shut down to preserve volume. All of these signs together are screaming hemorrhagic shock long before the blood pressure gives up.
And to standardize this, clinicians use the ATLS classification for shock, right? Based on blood volume loss.
Yes. That standardization is vital in a high-stress trauma bay. It gives everyone a shared language for urgency.
So class 1 is less than 15% loss. That's about 750 milliliters.
Pretty mild. You might see a slight increase in heart rate, but often there are no visible signs. You can usually manage that with IV fluids alone.
Class 2 is 15 to 30% loss, up to 1.5 liters.
Now we're in the active compensation phase. The patient's anxious, heart rate's up, but their blood pressure is probably still holding steady because of that vasoconstriction.
But this is where you need to be getting blood ready.
Oh, yeah. You need to be preparing for immediate replacement, even if DP looks okay.
Then class 3, 30 to 40% loss. This is the critical threshold. We're talking over 2 liters lost.
This is physiological collapse. The conversation breaks, and you see two profound failures here. First, hypotension finally hits.
There it is.
And second, critically, you see confusion or an altered mental status.
Because the brain isn't getting enough oxygen.
Exactly. The body can no longer sustain perfusion to the brain. At this point, you need immediate, massive blood product replacement, and you have to get control of the bleeding source now.
And class 4 is over 40% loss. It's collapse coma.
Catastrophic. At that point, you've lost over 2 liters of blood. Survival is measured in minutes and depends entirely on the speed of surgical control and activating the most aggressive protocols.
Okay, so given how vital it is to estimate this loss quickly, the source material gives some really concrete, memorable examples.
Yeah, these are great for mental shortcuts. For internal bleeding, you have to have benchmarks. For instance, a fist-sized clot is about 500 milliliters.
1 unit of blood.
Roughly, yeah. So that immediately gives you a sense of scale.
But the big hidden sinks for blood are orthopedic injuries.
Oh, absolutely. Think about a tibia fracture. That can easily hide 500 to 1,500 milliliters of blood.
And a femur fracture.
Even worse. A broken femur can bleed 1 to 2 liters. That single injury with no external blood loss can put a patient straight into class 3 shock.
2 liters. That's staggering.
But the absolute worst, the one that every trauma surgeon fears, is a pelvic fracture.
Why is this so bad?
Because the pelvis is this massive ring of bone, and behind it is a huge potential space, the retroperitoneum. It can bleed virtually unchecked into that space. We're talking 2,000 to 5,000 milliliters.
So their entire blood volume.
Or more. The patient can bleed out entirely inside their own body. If you see a pelvic fracture on an X-ray, you activate the most aggressive protocols immediately. No hesitation.
And for surgeons in the OR, there's a more direct way to estimate swab weighing.
Yeah, it's a standard, kind of rough technique. You weigh the surgical sponges when they're wet, subtract the dry weight you already know, and you get a running total of the blood loss. It gives the team a real-time score of whether they're winning or losing.
Which feeds right into that decision to activate the massive transfusion protocol.
Exactly.
So once that crisis is identified, we turn to the toolkit, the blood products. And modern trauma care isn't about just giving whole blood anymore. It's component therapy.
Right, because we need to be specific. The workhorse is PRBC-packed red blood cells. Their one and only job is to increase oxygen transport. That's the first priority because the most immediate threat is tissue hypoxia.
But if you only give red cells, you're just diluting everything else.
Which is why you need FFP, or fresh frozen plasma. This replaces all the crucial coagulation factors, the proteins that actually form the scaffold of a blood clot. Without FFP, you're just pouring in oxygen carriers that can't be held in place.
Then you have the cellular component, the platelets.
The platelets are the construction workers. They're the physical plugs. You give them specifically to treat thrombocytopenia, a low platelet count, which is inevitable in a massive bleed.
And the last one mentioned is cryoprecipitate. Why do you need this if you're already giving FFP for clotting factors?
It's all about concentration. Cryo is a highly purified concentrate of specific proteins, especially fibrinogen and factor VIII. In a really bad bleed, fibrinogen is often the first specific factor to just completely crash.
So cryo is like a targeted booster shot.
A very targeted, high-impact booster shot. It lets you deliver a huge dose of fibrinogen quickly without having to infuse massive volumes of plasma, which could overload the patient's heart.
So given all these tools, what's the goal? When do you actually transfuse?
The goal is stability, not perfection. The teaching material is really clear on this. For a stable patient, meaning the bleeding is controlled, a target hemoglobin of greater than or equal to 7 grams per deciliter is perfectly acceptable.
So you don't chase a normal number?
You absolutely do not, because every single unit of blood carries its own risks, which we'll get into. Chasing a higher number in a stable patient just increases those risks for no proven survival benefit. Keep them alive, keep them perfused. Don't worry about making the lab report look pretty.
And speaking of risk, the absolute non-negotiable safety net starts with blood typing. ABO and RH basics.
Yep, universal donor, O negative, universal recipient, AB positive, in a true lights and sirens emergency where you have no time to type and cross-match.
You reach for O neg?
You reach for O negative PRBCs every single time. It lacks the AB and RH antigens, so it has the lowest chance of causing a catastrophic immune reaction.
The source also gives that classic example of the Rh-negative mother and hemolytic disease of the newborn.
Which is just a perfect illustration of the immune system's memory, right?
Yeah.
An Rh-negative mom has an Rh-positive baby. Her immune system gets exposed and creates antibodies. In the next pregnancy, those antibodies can cross the placenta and attack the second baby's red cells.
A biological time bomb.
Exactly. Which brings us to the most sobering point in this whole section, the ultimate safety check. The source material says it bluntly, clerical errors kill. You can have the best surgeon in the world, the most advanced protocol, but if a simple administrative mistake happens and the wrong unit of blood goes to the wrong patient, it can be instantly fatal.
So those 4 checks are non-negotiable.
They are the last line of defense. Correct patient, correct blood type, right unit number, right timing. It has to be done religiously for every single bag.
Okay, so when the bleeding escalates beyond that standard replacement, we get to the massive transfusion protocol, the MTP. This is a hospital-wide emergency response. What are the triggers?
The MTP is designed to get ahead of the bleeding, not just react to it. So the triggers are unambiguous. The first is a volume over time metric, giving 10 or more units of packed red cells in a 24-hour period.
So basically replacing their entire blood volume in a day.
You're in MTP territory. But the more urgent trigger is about the rate of loss.
How fast they're bleeding right now.
Exactly. And that trigger is 4 or more units of PRBCs in a single hour. If a patient is burning through 4 units in 60 minutes, you are losing the fight. You have to switch immediately to proactive, massive resuscitation.
And this brings us to what's really the core concept of modern MTP. The golden ratio, 1 to 1 to 1.
This ratio, 1 unit of packed red cells to 1 unit of plasma to 1 unit of platelets, is a complete paradigm shift from how things used to be done.
What was the old way?
Historically, the focus was just on oxygen and blood pressure, so doctors would slam in huge volumes of red cells and saline solution. And yeah, they'd fix the oxygen deficit for a minute, but they'd flesh out all the patient's own clotting factors and platelets.
Creating that dilutional coagulopathy we talked about.
Right.
You solve one problem by creating another.
And that new problem, the inability to clot, was often what killed the patient, even if the surgeon fixed the hole. The 1.1.1 ratio is revolutionary because it says from the very first unit, we're replacing everything they're losing simultaneously. We're trying to give back whole blood, just in its component parts.
So you're restocking the supply cabinet as fast as they're emptying it.
That's it. And the data is overwhelming. It has led to significant reductions in mortality. It just works.
But the MTP isn't just about blood products. The source material points to 3 crucial adjuncts, 3 non-blood therapies that have to go with it.
Yes. And these are essential to make sure the blood you're giving actually works and doesn't cause more harm. First, you have to warm the blood products.
You mentioned they're stored cold.
Frigid, 2 to 6 degrees Celsius. If you pour liters of that into a person, you are guaranteed to cause iatrogenic hypothermia, which shuts down the clotting enzyme. So you have to use high-flow blood warmers. It's not optional.
Okay, number 2 is calcium supplementation.
Right. This is pure chemistry. The preservative in blood bags is citrate. And citrate loves to bind to ionized calcium. So as you pour in citrated blood, it mops up all the patient's available calcium.
And you need calcium for clotting and for the heart to beat properly.
Absolutely. So you get clotting failure and dangerous cardiac arrhythmias. We have to give calcium back proactively and aggressively.
And the third adjunct is a drug, TXA or tranexamic acid.
TXA is an antifibrinolytic. In simple terms, it helps stabilize the clots that do manage to form by preventing the body from breaking them down too quickly.
It's like a reinforcing agent for the clot.
A perfect analogy. It puts the brakes on the body's natural clot-busting process, which can go into overdrive in trauma. It's a proven lifesaver.
Which brings us to the analytical peak of this discussion, the lethal triad, the cycle of death. It's made of 3 interlocking elements, hypothermia, acidosis, and coagulopathy.
And this is a true runaway feedback loop. The source material puts it so simply and starkly: cold blood doesn't clot. Acid blood doesn't clot. If you let a patient's internal environment get cold and acidic, their own biology will prevent them from stopping the hemorrhage no matter what you do surgically.
So the goal is simple: break the cycle and break it early.
That's the only goal that matters, because each element feeds the other 2. The patient gets cold, that's hypothermia. Their clotting enzymes fail, that's coagulopathy.
Because they can't clot, they bleed more, which makes the shock worse.
And worsened shock leads to anaerobic metabolism, which produces lactic acid. That's acidosis. And acidosis further impairs the enzymes and platelets, making the coagulopathy even worse, which makes them bleed more, which makes them colder.
And the loop closes.
The death spiral.
Okay, let's break down the instigator here, hypothermia. Why does a massive bleed make a patient so cold?
4 main reasons. The first is obvious. You're losing warm circulating blood. Blood is how your body distributes heat. Lose the blood, lose the heating system.
Second, as we just said, you're infusing cold blood products.
You're actively refrigerating them from the inside out if you're not careful. Third, in the operating room, you have massive heat loss from the open surgical field. Evaporation is a powerful cooling process.
And finally, the anesthesia itself plays a role.
It does. It suppresses the body's own thermoregulation. The patient can't shiver effectively or constrict vessels in the right way to preserve core heat.
And the critical link is how this cold temperature directly causes clotting enzyme dysfunction.
It's pure biochemistry. The clotting cascade is a series of enzymatic reactions, and those enzymes are proteins optimized to work perfectly at 37 degrees Celsius. When the core temp drops to, say, 34 or 35 degrees, the reaction rates just plummet, the platelets get sluggish, the whole cascade just stalls.
So cold means inefficient clotting, which leads to more bleeding and more shock. And that shock is what causes the second pillar acidosis.
Exactly. When the body's in profound shock, it can't deliver enough oxygen to the tissues. So the tissues, desperate for energy, switch from their normal aerobic metabolism to an emergency backup, anaerobic metabolism.
The quick and dirty energy pathway.
Quick, dirty, and it produces a ton of waste product, namely lactic acid. This floods the bloodstream, overwhelms the body's buffering systems, and the blood pH plummets. That's systemic acidosis.
And just like the cold, the acid sabotages the clotting system.
It deactivates it. A change in pH physically changes the shape of the clotting factor proteins. They literally can't link together anymore to form a stable clot. It stops the enzymes just as effectively as the cold does.
So to recap the cycle, bleeding causes shock. Shock causes acidosis from lack of oxygen and hypothermia from volume loss. Both the cold and the acid cause coagulopathy clotting failure, which of course causes more bleeding.
And around it goes until the system collapses completely. The takeaway is that you have to attack all 3 points of the triangle at the same time. You can't just fix one.
All right, so if we understand the triad, we know how to prevent it. The source material lays out some very practical steps for the operating theater, starting with fighting hypothermia.
Yeah, and this is an active battle. It starts with the environment. You have to keep the OR warm. The target is 24 degrees Celsius or higher. The surgical team might be sweating, but the patient's life depends on it.
And what about active rewarming tools?
We use forced air warming systems like the bear hugger, which is basically a blanket that blows warm air over the patient. And critically, you have to warm everything going into the patient. Body fluids, irrigation solutions. You can't pour cold fluid into an open abdomen. It's like an internal ice bath.
Minimize exposure, cover everything you can.
And monitor the core temperature constantly to make sure what you're doing is actually working.
So we know how to fight the triad, but the very treatment we're using, the MTP, introduces its own set of life-threatening complications.
It's always a trade-off. We're pushing massive volumes of stored, biologically active material into a failing system. Complications are inevitable.
Let's start with the big chemical imbalance. Hypocalcemia. We touched on this, but why again does giving blood make calcium levels crash?
It's the citrate preservative. Citrate is a chelating agent, meaning it binds to ionized calcium. As you flood the system with citrate, it just mops up all the patient's free, usable calcium.
And without calcium, no clotting, no heart function.
Which is why we have to give it back. Aggressively.
And then there's the opposite problem with a different electrolyte, hyperkalemia, hypotassium.
Right. This is from what we call the storage lesion. As red blood cells sit in a bag for weeks, they slowly start to break down, and the potassium that's normally inside the cell leaks out into the surrounding plasma.
So when you transfuse that unit,
You're dumping a big load of potassium into the patient. If you do that with multiple units quickly, you can raise their potassium to dangerously high levels, which can cause the heart to stop.
and even with our golden 1.1.1 ratio, we still have to worry about dilutional coagulopathy.
We do. The ratio is designed to prevent it, but if the bleeding is just unbelievably fast, or if the team has to give a lot of other IV fluids to keep the pressure up, you can still dilute the patient's remaining factors. You have to be constantly checking labs to make sure the ratio is keeping up with the reality of the loss.
And finally, the really scary ones. The pulmonary complications. ARDS and trachea.
Trachea transfusion-related acute lung injury is probably the most feared non-infectious complication. It's an immune reaction. Antibodies in the donor's plasma can attack the recipient's white blood cells.
And what does that do?
It causes those white cells to clump together and clog up the tiny blood vessels in the lungs. This triggers a massive inflammatory reaction, and fluid just pours into the lungs. The patient essentially drowns hours after the transfusion saved their life.
That is a terrible trade-off.
It is, and it's why you never give a unit of blood unless it is absolutely necessary.
Okay, this deep dive has been incredible. We've gone from the basic chemistry of a clot all the way to hospital-wide protocols. Let's distill this down to the final takeaways from the source material, the ultimate clinical pearls.
Slide 16 gives us the absolute #1 foundational directive of all trauma care. Stop bleeding first.
Yeah.
Everything else, the warming, the transfusions, the protocols, it's all just a bridge to buy time until you can achieve definitive surgical control of the hemorrhage.
So you're warming the patient while you're racing to the OR.
At the same time, and you're activating the MTP immediately with that relentless focus on preventing all three parts of the triad. You attack the source and the physiological fallout simultaneously.
And that brings us to the final clinical pearl, which I think really summarizes the whole philosophy here. Don't chase HB numbers, treat the bleeding patient.
This is such a profound statement about clinical judgment over lab data. In the chaos of the trauma bay, the patient's physiology, their heart rate, their mental status, their core temperature, how fast they're still bleeding, that's a much better guide than a single hemoglobin number from the lab that might be 20 minutes old.
So focusing on getting that number from a 7 to a 9
Yeah.
might actually distract the team from what's really important.
It absolutely can. If the patient is still bleeding out, giving more blood is just feeding the fire. It's accelerating the triad by pouring in more cold, citrated product. You have to treat the dynamic living crisis in front of you, not the static number on a computer screen.
And with that, we've come to the end of this deep dive. We've taken a surgeon's teaching tool and found a blueprint for high-stakes decision-making. And the real value isn't just knowing the parts, but understanding that lethal cycle they create when they fail.
The ability to see those early signs of compensation, that tachycardia without hypotension, and to get ahead of the lethal triad, that's what has transformed trauma care. It's a victory of proactive scientific understanding.
Which leads us to a final provocative thought for you to take with you. We know MTPs save lives, but as we just discussed, they carry these unavoidable risks, telangiectasia, hyperkalemia, all tied to using stored donor blood. So given those complications, what emerging technologies, beyond just better warmers, might stabilize the clotting process entirely without relying on donor products?
Yeah, what's next? Should future research focus on, say, synthetic oxygen carriers that don't have a storage lesion? Or maybe developing trauma dressings that are impregnated with stable recombinant clotting factors designed to work even in a cold, acidic environment? The quest to perfect this process, to eliminate the risk of the very antidote we're using, is really the next frontier.
A vital area for future exploration. Thank you for joining us on this deep dive into the protocol that saves lives against the clock.